3. Perinatal medicine. Perinatal medicine aims to provide a seamless care pathway for the fetus and infant, with complex problems from before and during pregnancy, through labor and delivery into the neonatal period. This requires expertise that is highly specialized, rapidly advancing and multidisciplinary. In many countries, this involves close collaboration between specialists in maternal, fetal medicine, high-risk obstetrics, neonatology and pediatrics. Such care is usually provided centrally as a tertiary service, although some services are available locally or as shared care. Figure 3.1. Screening for risk factors, blood tests, ultrasound and antenatal visits. Pre-pregnancy assessment. Antenatal care. Low-risk delivery and healthy baby. Significant complex problem identified in fetus or mother. Serious problem with baby. Perinatal center. Commonest problems. Fetus. Maternal fetal medicine. Fetal medicine. Structural anomaly on ultrasound scan. Increased risk of fetal abnormality from blood screening test or scan, for example, trisomy 21. Down syndrome. Intrauterine growth restriction, IUGR. Feto-fetal transfusion syndrome. Multiple gestation. Mother. Maternal fetal medicine. High-risk obstetrics. Pregnancy-induced hypertension. Chronic hypertension. Maternal diabetes, chronic illness, cardiac, renal, etc. Recurrent miscarriages. Preterm rupture of membranes chorioamnionitis. Preterm labor. Infant, preferably transferred in utero, otherwise postnatally. Neonatal intensive care or specialist pediatric services. Very preterm, less than 32 weeks gestation. Mechanical ventilation for more than 24 hours. Hypoxic ischemic encephalopathy. Inhaled nitric oxide, INO, therapy. Neonatal surgery. Specialist pediatric services, cardiac, renal, metabolic, neurosurgery etc. Extracorporeal membrane oxygenation, ECMO. Other specialist services. Genetics. Perinatal pathology. Advantage of perinatal centers. Ready access to specialists in one place. Allows rapid development of experience with rare problems. Improved outcomes, data inconclusive. Facilitates staff training and research. Cost-effective use of scarce specialist expertise. Potential disadvantages. Parents may have to travel away from home. Deskilling of staff at other centers. Creates hierarchy of care. Need dedicated transport service. More difficult to ensure good communication with local healthcare services because of geographical separation. Figure 3.1. Organization of tertiary perinatal care. Neonatal involvement in perinatal care. An increasing number of conditions requiring specialist neonatal or pediatric care are recognized antenatally. This allows counseling, both obstetric and pediatric, multidisciplinary discussion and transfer, if necessary, to a perinatal center. Parents require discussion of complex information about their baby's condition and management options, often on multiple occasions and with several healthcare professionals. These may include neonatologists, specialist pediatricians, and pediatric surgeons. Interpretation of antenatal ultrasound scans may be difficult and defining prognosis may be problematic. This is facilitated by multidisciplinary team, MDT, meetings of relevant specialists, which may include fetal medicine, obstetrics, genetics, neonatology, and pediatric surgery. Other pediatric specialists such as those involved in urology, neurosurgery, otolaryngology, ENT, orthopedics, and pediatric medical specialties may also be involved. Examples of perinatal care. Significant fetal abnormality diagnosed on prenatal ultrasound. An example is an omphalocele, figure 3.2. Another is a diaphragmatic hernia, requiring antenatal planning for infant to be transferred for ECMO, figure 3.3, and neonatal surgery. Fetus diagnosed with supraventricular tachycardia, SVT. The mother is treated with oral flecainide, transplacental therapy, to control the fetal heart rate and rhythm and prevent heart failure. Performed in conjunction with pediatric perinatal cardiologists. The neonate is delivered in a cardiac center to optimize medical management and radioablation of an accessory conduction pathway. However, specialist assessment and counseling need to be prompt to allow parents to make informed choices, including termination of pregnancy, in order to keep within national legal boundaries. Information about less severe problems identified antenatally also needs to be communicated to the neonatology and specialist pediatric teams so that appropriate assessment and follow-up are arranged postnatally. Neonatal networks. The different levels of care required by newborn infants are shown in figure 3.4. As it is not possible or efficient to provide all levels of care in every hospital, neonatal or perinatal, including maternity, networks working across hospital boundaries have been developed. Their aim is to improve care for mother and baby by facilitating collaborative working, unified protocols and minimizing geographic variations in care. Figure 3.2. Significant fetal abnormalities detected on prenatal ultrasound screening, such as the omphalocele, arrow, shown, will need to be assessed in a perinatal center to allow review by a fetal medicine specialist, neonatologist and pediatric surgeon, counseling with parents and planning for delivery and management. Figure 3.3, an infant on extracorporeal membrane oxygenation, ECMO, which is provided at only a relatively small number of specialist centers. Figure 3.4, levels of neonatal care. Normal care. Takes place in maternity units. No specialist pediatric input required. In the U.S. Level 1, well newborn nursery. Neonatal resuscitation. Stabilize and care for stable infants from 35 to 37 weeks. Stabilize and transfer if ill or less than 35 weeks. Level 2, special care nursery. Infants greater than or equal to 32 weeks and greater than or equal to 1500 gram and short-term illness, otherwise stabilize and transfer. Mechanical ventilation less than 24 or CPAP. Level 3, NICU, comprehensive care for all infants. Full range of respiratory support including inhaled nitric oxide. Advanced imaging including CT, MRI and echocardiography. Prompt access to pediatric medical subspecialists and surgical specialists. Level 4, regional NICU. Surgery for complex conditions. Full range of pediatric medical subspecialists. Facilitate transport. In the UK, transitional care. Usually from 33 to 37 weeks. May be on postnatal wards or separate unit. Mothers care for own babies with support. Special care units, SCBU, care for local population. Some provide some HDU care. Local neonatal units, LNNU. Special care, high dependency and very short-term intensive care, less than 48 hours. Usually more than 27 weeks. May take in some babies from other network SCUs. Neonatal intensive care units, NICU. All gestational ages. Provide all levels of care including nitric oxide and therapeutic hypothermia. Advanced imaging available. Co-located with specialist obstetrics and fetal medicine. Often located with cardiac, surgical or pediatric subspecialties.